Good afternoon, everyone. I wish to thank the chairman of this session and the members of the committee for the gracious invitation to this meeting and the meetings over the years. It is and has been my honor. My topic, in search of optimum cardiovascular health, meds versus meds, of course, referring to cardiovascular fitness, I will be discussing how exercise and medication can be combined for better health outcomes. Over the years, advances in pharmacology have contributed significantly in the management of chronic disease. Of course, the use of any medication of therapy is based on a favorable risk-benefit ratio, as all medications are controlled poison and therefore have inherent risks, as we are reminded by the pharmaco and pharmaki in the Greek, in our language. Questions, of course, can we improve the risk-benefit ratio by combining medications with physical activity? That's one question. In other words, is there a synergistic effect? Can the two work together for better outcomes? Another question will be, is there an independent effect of exercise? Because if exercise can do the same things as medication, certain people cannot tolerate medication, perhaps we can do exercise for them, just only exercise. And of course, if yes is the answer to those questions, we have public health implications, which are very, very significant. Now, what is the information regarding this, the effectiveness of exercise, that is, on preventing or managing disease? There have been some. In this particular study, which is a meta-analysis, we see that the authors concluded in the population of hypertension, most exercise interventions appear to be as equally effective as most antihypertensive medications. What about fitness and diabetes? We do know from the diabetes prevention program that lifestyle did as good, if not better than metformin, and certainly placebo in preventing the diabetes incidence. In this particular meta-analysis, we also see that the pooled estimate, the benefits of exercise appear to outweigh the benefits of medication at the end of the treatment. However, we see something very interesting. The follow-up of 5 to 9 years for lifestyle intervention trials versus medication trials, we see the lifestyle intervention follow-up was 5 to 9.4 years, and we see still that these interventions are effective in lowering the incidence of diabetes, whereas interventions with medication do lose their effectiveness within weeks. In this particular study, where they looked at the standard therapy versus lifestyle, and when A1C levels increased in this group, they increased the medication. When they decreased, they withdrew medication. As you can see here, in the standard care group, medication increased by 44% plus, whereas in the fitness and the lifestyle group, only 10%, and there was a reduction of 56% plus of medication, where it's only 14%, 15% in the standard care group. What do you see here? You see a much better control of A1C in this group, although they kept withdrawing medication and then they kept increasing medication here. Unfortunately, the conclusion is not as it should be, more favorable to the lifestyle, but they downplayed the effects of a lifestyle. And in fact, there was a big thing, the media in the United States, that there was an outcry of scientists throughout the United States. We mentioned there are some consequences. There are some undesirable consequences with medication, and one of it being that statins inhibit CoQ10 in the complex 1 electron transport chain leading to increased diabetes. At least that's the theory. And we looked at this to see if there is any way that can fitness attenuate this risk? And sure enough, when we looked at fit individuals versus unfit, we see a lower incidence of diabetes in the high fit versus least fit. In say 15 years, we still see about approximately 75 versus 65% of patients in diabetes free. What if we combine statins with exercise? Well, we looked at this as well. This group is comprised of individuals on statins, on no statins, and this 1, 2, 3, 4 groups, individuals who were receiving statins, although of different fitness. As you can see here, high fit individuals have absolutely no risk, no increased risk of diabetes when compared to a non-statin group, where you see here the moderate fit, no increased risk of diabetes, and we see an inching up, a little bit increase here of 22% in the low fit, and certainly 50% increase in the least fit individuals on statins, which overall this study suggests that the incidence of diabetes, number one, can be attenuated by fitness, and they're concentrated basically on the unfit people. We also did this particular study where we looked at dyslipidemic patients, and we looked to see if statins versus medication, which one is more effective in lowering mortality. As you can see here, statins lower mortality by 35% in this particular cohort of ours, which is very, very close to what the other studies have shown. But we do see here a graded reduction in risk of mortality between 26 and 63% in the group that was fit versus unfit. So the higher the fitness, the lower the mortality risk. Here is the two groups side by side, statin group, fitness group, no statins. This is statins, this is no statins. As you can see, the trend is very similar, but it does appear that statins have a little bit of advantage over fitness. So we combine the two, fitness, statins versus no statins. So in each particular group, least fit, low fit, moderate, and high, we have those with taking statins and those not taking statins. So the white bar is the no statin group, and you can see again the same trends. However, if you look at the least fit, all the increase in the mortality here is concentrated on this particular group, the least fit, not on statins. But when you go from here to the next fitness category, this 35% increase in mortality is wiped out just by being a little bit of fit. And of course, you have a reduction in mortality as you become more and more fit. Approximately 20% here and approximately 50% in this group. So it appears that the increased risk is concentrated on those who are not fit. We also did another study where we looked at the renin-angiotensin system inhibition, and to see if indeed we can intervene with exercise there to reduce mortality risk. So the question is, if we use the renin-angiotensin inhibition, we know that it's reducing mortality risk. And if we look at fitness, as I mentioned it, fitness also reduces mortality risk. What if we combine the two? Could we get a greater reduction in mortality risk? And that was the premise of the study, or the hypothesis, or our goal. And what we see, of course, is that, let me go quickly to the study. Of course, we had over 11,000 plus patients, hypertensive, diabetes, obesity. They all had risk factors. And what we did, we stratified the group based on fitness, of course, RAS versus no RAS in every fitness category. And so two groups per fitness category. And we applied multivariate Cox proportional hazard models and so forth. I want to tell you that we adjusted for all possible variables, and we used the least fit ACE category as the referent group. So what did we find? Okay, index. Okay, what did we find? During the follow-up period of 13 plus years, there were approximately 3,600 people who died. Patients treated with RAS had 20% lower mortality than those not treated. So RAS inhibition was effective, but look at what happens with fitness. Well, a dose response and inverse association was observed between fitness and mortality risk. The mortality risk was 12% lower for each 1 med increase in exercise capacity. Now, if you look at this least fit, low fit, moderate, and high, you see again this graded association, this graded association, an inverse and graded association between fitness and mortality. As you can see here, the Kaplan-Meier curves, they show the same thing at 15 years, better off being fit than unfit. And when we combine the two, and again, least fit, low, moderate, and high, and in each category we have those on ACE in the green bar versus no ACE in the red bars. And so what we see again, if you are least fit and you are not on ACE, you have an increased mortality. However, if you are a little bit fit, the next fitness category, this increase in mortality is attenuated by 14%. Please concentrate on the red bars, as I said before. If you go to a little bit more fit, 27% reduction in mortality. And if you go to the high fit, 35% reduction in mortality. Please keep in mind that this is compared to the green bar here. That is, without medication, just fitness, you achieve a lower risk of mortality. Of course, if you combine the two, you're doing much better. Conclusions: in higher risk patients, both RAS and increased fitness were associated with lower mortality, and the combination of two was even more effective. So I would like to I would like to pose this question. When you are looking at someone's risk, a patient such as this one has a 28.7 risk based on the Framingham risk score. However, this particular risk underestimates this group and overestimates this group, because those cannot be the same. If the risk is 28.7, this is a mean risk, and a mean risk of all this, and you cannot tell me the high fit individual has the same risk as this individual. So overall, it's underestimating this risk. This group, these people have much higher risk than this, and these people have much lower. That's why you have this. So please consider fitness status of the patient when you are assigning risk to that patient. And I want to thank you for your time and your attention.